Still focusing on the right setting of care, data showing from the MDS showing that the majority of new nursing home residents new to Medicaid, the majority of new nursing home residents for Medicaid enter from other settings of care, other institutional settings of care, actually. And that emphasizes the need for more integrated long-term service and supports onboarding. Actually, this is a very different result than I thought, than I expected. I didn't know this. All of you who work in the industry probably did. But 85% of nursing home residents come from another institution, rehab facility, especially the community hospitals. And that only 15% are coming from the community, and we'll talk a little more about the process for community-based enrollment as it currently stands. This is important because it helps to frame this question of consumer choice, this question of rebalancing, this question of of where an individual is treated at any level of need or served. Because in this case, just in terms of process, a DHS delegate or employee, I don't believe comes into contact with 85% of nursing home entrants until after they're already in the nursing home. So that's absolutely going to color and frame our question of how to address enrollment eligibility in that process. Because these things happen very quickly, they can happen over a course of a day or two, et cetera. And that's very different than someone who, with their family, comes to the conclusion, I need help, comes to the county office, et cetera, makes the call, makes a deliberate decision in advance to apply for waivers or for nursing home services. That's, from the perspective of the nursing facility, apparently only about 1 in 6. One of our goals is to be able to look at more than just Medicaid data. We feel like we need Medicare. We're trying to pursue Medicare data. It's not easy at all. I believe this is just Medicaid. Other questions or comments about this distribution? Again, it really was different than I expected. I'm relatively new to long-term care, and I was imagining this deliberate decision process that individuals make in advance. And from the nursing home perspective, that's kind of not reality. This is the process that we have now. This is only descriptive. This is the process we have now. Long-term care patient journey today really has separate processes for individuals, because an individual makes a very, for those who come from the community, it's really implicitly true for those who are transferring out of an institution, they are making a choice early on to pursue waiver or community-based services or nursing home services. Before, in many cases, before they've been assessed for their level of need. Starting at the bottom, the pictures are interesting. Starting at the bottom, the client applies for long-term services and supports. That's where the process of obtaining financial information, assets, income. And that's the point at which they decide whether they're applying for one kind of service or the other. Again, this is for the community-based journey. And so the next stage is to either be approached by a DHS nurse for the 703 to be filled out, or for that to occur at the nursing home, and have the 703 and the MDS applied at the nursing home. really two separate processes now, and a little bit of a misordering in that the individual is choosing what they think they need before they've had the benefit of an external systematic evaluation of that need. This is not how the rest of medical care works in general, except for those. I think an analogy, though, would be a health insurance plan that allowed individuals to go straight to the specialist, straight to the surgeon. That's maybe a little bit of an analogy. And then at the far right, you see a little bit about what happens over time. The waiver client's eligibility is updated annually, again by the DHS nurses. The nursing home client's MDS is also updated annually or quarterly, while the 703 is updated only if the status changes. How often would it be quarterly versus annually for the MDS? Can someone help me with that? Usually quarterly, almost always. Would it be fair to say most residents end up with closer to quarterly than annual?
I don't have an annual anymore.
Well, in other words, most aren't waiting a full year. Most are getting it. Okay, it's quarterly. I think the answer here is it's quarterly.
I think when I saw this page, I think you said something also in your comments that clients are applying for what they think they need. And I think that's very true possibly in some waiver programs. But that is a false premise that this whole page is on, is that nursing home patients are there because they choose to go there. They're there because they have to go there. And I think that's never, in all of our discussions, in many areas, we never really admit that. So any system that we put in place that doesn't take into consideration that was a last resort for that family or that patient, and it was a very difficult choice, that needs to be included in this. Right?
I think it's a fair point, Jim, and you're absolutely right on both counts. I don't assume people prefer to leave their home and go to a nursing facility, and I also don't assume that they haven't made a judgment about need. And in some of the comments I made earlier about nursing facilities, we just don't have the data yet, but it's highly likely that we will find after implementing the universal assessment that there are some individuals receiving community-based care that don't meet the minimum threshold. We're predicting that will happen. We don't have the data yet, so we're a little ahead. Because of the MDS and that quarterly collection, we have all kinds of data for nursing facilities. We just don't have all that much data for the community-based service yet.
I think one thing that you have to take into consideration is the amount of time that it takes to get on a waiver. So when a person has a need all of a sudden for care and it's going to take them 3 months to get on a waiver, then they do feel like their only choice or their only need is a nursing home. But there is such a disparity in the time it takes to obtain those services that I think that needs to be looked at as well.
And for the community-based services, and the key distinction there that we're aware of is, in particular, the financial eligibility for Medicaid by the nature of a community-based service is not viewed as emergent, that sort of thing. And so we wait to determine eligibility until we know that the financing is there. An individual in need is transferred to the nursing facility before you all even know whether they're going to qualify for Medicaid. So I'm assuming there's some losses taken there. It's partly that acuity of need that's driving that distinction and the delay that it takes in community-based services, which is largely described. There's the assessment, but which we're implementing to accelerate. But that financial eligibility is sometimes pretty thorny. We get, I took questions just yesterday on the accuracy and the intensity of DCOs. The scrutiny of DCO applies for financial eligibility. Assets, are they being hidden, et cetera. And that really takes up a great deal of time.
And Dr. Ellison, I think too, Joni Jones, we've had several meetings. Obviously, you're probably aware with on the different county offices and the different things they've moved around. But I know with nursing facilities, of the large majority of nursing facilities take the residents in because there's nothing else for them to do and don't want to leave them on the street. And I know my organization, we lose hundreds and hundreds of thousands a year because we can't. There is on some of that movement in and out. They come into our nursing facilities. It takes so long to get them approved, and we're taking care of them and paying for it out of our pocket. We give them therapy and super shakes and supplements, and 90 days later they've improved. And when they finally get there, they don't qualify, and we eat all of that. And we would welcome something that would make that some type of quicker process. But that's what they don't qualify for home and community-based services or something. And when they end up in our facilities, the large majority of us take them in and we pay for it out of our pocket while we're waiting on them to get approved. And most of them do, but when someone doesn't get approved for 3 or 4 months before they get that back, I mean, there's hundreds and hundreds of thousands of dollars that we eat, and that cost is not reflected anywhere in here because there's no line on it on the cost report.
This is a distribution of average costs across client for those served in the different settings of care, and this would include just the long-term service and support costs, not the halo, not the medical care. Obviously, institutional-based care qualitatively is different. There's room and board included, so we would expect a discontinuity in that the nursing homes would be farther to the right. And so you see at the bottom, it's thousands of dollars per year is what you see at the bottom. So up to, I think, $55,000. That range is the average for nursing facilities, and you're looking at an average of about $15,000 for elder choices, and between $15,000 and $20,000 for AAPD, and assisted living is closer to $25,000 on average. And you see there a great deal of variation. In elder choices and AAPD, less variation in assisted living, and some variation, as you've already seen, with the nursing facilities. When we have obtained data on RUG levels from the community-based clients, we will be able to do this chart, but instead of arraying by average, we could actually compare average costs, the distribution for each RUG level, so for similar level of need according to those instruments, the MDS and the inter-RAI. Not able to do that right now. Obviously, if there are individuals who are, and this is not how they're arrayed, but if there are individuals who could be served in either location, it raises a couple of important questions. How much assistance should the state provide in amount and in dollar terms in either location? What's the nature of the choice that an individual has? Understanding the very profound and difficult questions we're facing today about public spending and Medicaid, what is the nature of the choice that we really, as a state, want to put in front of individuals? The resource allocation is so vastly different. You might say two things. You might say, well, it's just a question. I don't think it is. You might say, well, it's just a question of institutional or non-institutional. Maybe it isn't. Well, the conversations we'll want to have, going forward is, what really is that marginal individual? What's the nature of their need? What would it take? How much would it cost? Where are they in the HCBS or the other waiver? Where are they in that distribution? The person really at the margin of needing to go in an institution, etc.